Hi everyone, welcome to week 1 of DEN 200, Expanded Function Dental Assisting. My name is Alexis DeWater. I will be your professor for this course. We have a lot to cover this week, a lot of basic things that you probably already know, some new things as well though, just kind of all of those basic things to put together to start learning about EFDA. So let's get started. First, welcome to the program. We're so excited to have you. If you ever have any questions about anything, reach out to us. You'll learn a lot more in your lab classes as well, all those hands-on components. So this is going to feel like a lot of lecture and talking. I promise the lab component of it will be a lot more fun and interesting because we've got all of this out of the way already. I did want to start talking about professionalism and how important professionalism is as an EFDA. So what is professionalism? It refers to the way that you behave and represent yourself, especially in a business setting. So as an EFDA, we want to be acting really professional while we're working on patients, while we're in the dental office, because we do have a license and we need to uphold that responsibility of having the license. So I'm sure everyone displays professionalism in their current position, but we even may need to take it up another notch when we become EFDAs. So let's talk about some different ways that we can deliver professionalism. Communication is huge. We always want to deliver professional, thoughtful, positive communication. We never want to talk down on anyone or use profanity, things like that. Having good health. So we want to make sure we're resting enough, eating right, exercising some. We just don't want to let ourselves kind of like slow down and get super tired, especially while working on patients. Good grooming. We want to make sure that we're bathing and smelling okay. We're brushing our teeth because we're going to be right in patients' faces. So we want to make sure that we smell good. Appropriate dress. So scrub should be clean, wrinkle-free. When we're wearing jewelry, we should consider infection control. So things like dangly earrings or long necklaces, things like that we want to avoid because they can be contaminated and they're very hard to clean then. So keeping jewelry to a minimum and making sure that our scrubs are clean and freshly pressed. Teamwork, super important. Especially when you're working in an office, you're going to be the dentist teammate, you're going to have other assistants and EFDAs working closely with you, the hygienist, the front desk, sterile techs. There are so many people that we need to work in a good way with, that we need to help out and just make sure the office is flowing nicely. So teamwork's really important as well. Attitude. Our attitude is everything. I had an old coworker who may not have had the best days, and that would then reflect on my personality. So by her having a negative day, it made me feel like I was having a bad day as well, and then it kind of just went around the office and everyone felt like they were kind of having a bad day. So by just staying positive, it helps others to stay positive. So even though you may be feeling like you're having a bad day, just try to stay positive at work and help others have that positive mentality as well. Be appreciative as well, so don't take anything for granted. Dedication. So we want to make sure that we're dedicated to not only ourselves, our team, our patients, everyone in the office we should be dedicated to, and that includes just like showing up on time, making sure you're doing your job appropriately, things like that. Responsibility and initiative. So again, being on time is huge for professionalism. We don't want to be rolling in late every day with coffee in hand, breakfast in hand, things like that. We want to show up with plenty of time before our shift starts so that we can open the office, get everything ready, get our first patient set up. Be willing to learn is huge too. So we never want to feel like we know it all. Kind of like having that humbleness to us, that there's still room to grow and we can continue to learn. Alright, so operator and patient positioning. Kind of basic stuff, but we are going to be having a competency on just basic body positioning, so I thought this was important to go over. As an EFDA, and I'm sure as a dental assistant you've experienced some back pain just from the way that we're sitting and our posture throughout the day, so we should learn to try to strive for optimal body positioning that's more ergonomic, so that way we're not feeling the effects of this down the road. So sitting in the wrong position all day, every day can lead to a lifetime of pain in your back, in your neck, joints, things like that. So we want to try to prevent that. Alright, so positioning as the operator, that would be when we're in the like the dentist chair, essentially placing a filling by ourselves, we would be considered the operator in that situation. So we want to be seated as far back as possible in the chair with front edge of the stool just touching the back of the knees, thighs parallel to the floor or knees slightly lower than the hips, feet flat on the floor and not crossed. Backrest of the chair is positioned to support lower portion or small of the back. And height of chair should be maintained to keep the operator's forearms parallel to the floor when bent at the elbow. So we don't want to be working with our arms up in the air. We don't want them to be like this. We kind of want them to be parallel and even with the floor when we're holding the mirror and explorer and working in the patient's mouth. So then next, if we're positioned in the dental assistant stool, here are some just appropriate ergonomic ways we can sit there. So we should sit well back on the stool. We don't want to be leaning forward too much. We should have our back touching that backrest. Feet should be resting on the base or foot ring of the stool. So we shouldn't be trying to have our feet on the floor because that may be a little bit of a reach, because we should be higher than the dentist. So our feet should not be touching the floor unless you're super tall. They should be on that round metal foot ring that's at the base of the chair. Position as close to the dental chair as possible. We want to be close to our patients. We don't want to be like reaching and our arms are fully stretched out. Legs should be parallel to the patient's chair. Eye level should be 4 to 6 inches above the operator. So we should always be above the dentist, seated a little bit higher so that we have a better visualization of the mouth. Alright, so let's get into how the patient should be positioned. We should lower patient into the supine position with head even to the top of the headrest when doing a lot of work that we're going to be doing. Patient should be instructed to turn to the left or right to allow easier access to specific areas of the mouth. So instead of ourselves moving our bodies to accommodate like a left or right side, we should just ask the patients to turn their head for us. So they're coming to us instead of us coming to them. Working distance between patient's face and operator's face should be about 12 to 14 inches apart. So we don't want to be right up in their face. We don't want to be super far away. That about 12 to 14 inch mark is perfect. And when working on the mandibular jaw, the back of the chair is raised slightly more upright for better visualization. When that patient is leaned forward a little bit, we're able to see into those bottom, especially with the bottom incisors, the lingual side of it. We can see it a bit better if they're leaned forward a little bit there. Motion economy. So we're going to talk about different ways that we can move our fingers and wrists to transport instruments or pick up instruments, use instruments. So step 1 of motion economy, or part 1, we'll say, is movement of fingers only. So if you're just picking up an instrument, just using your fingers. Next would be part 2, so movement of fingers and wrists together. So if we go from picking up an instrument with just our fingers to then transferring the instrument to the dentist, that starts to involve the wrist portion. Next, we have movement of fingers, wrist, and elbow. So that would be things like using a handpiece where we're needing to kind of move around a little bit more freely. Number 4, use of entire arm and shoulder. That is going to be when we're reaching for items like across the tray, things like that, where we're needing kind of like our whole upper body. And then bending to see into the mouth would be part 5. Like we're truly using our entire upper body, including the abdomens. Whereas step 4 is more so just like the shoulder area. Different operating zones. So they are based on the concept of a clock. They identify as the working position of the dental team, supplies, and the equipment during treatment. So on the first side is the right-handed dentist side. So typically most dentists are right-handed. I've come across a few that are left-handed. So whatever dentist you're working for, first figure out if they're left-handed or right-handed, and then you can go off of this clock model to see where things should be. So in the right-handed dentist zone, for instance, from 7 to 12, that is the dentist zone or the operator zone. If us as EFDAs are in there doing a filling, that would be our zone. So whoever's in that operator chair. 12 to 2 for right-handed dentists is the static zone. So not a whole lot going on back there. Some people will keep their instruments back there, their trays back there. Usually the computer is back there. But not a whole lot of movement going on. 2 to 4 then is the assistant zone. So we have a smaller zone because we're keeping everything really close by. And then from 4 to 7 is the transfer zone. So that's where we're going to be transferring instruments and other materials to the dentist. It's kind of opposite though for left-handed dentists. So again, just be sure you're familiar with what method your doctor uses, what hand they use and prefer. So next we're going to talk about direct versus indirect vision. Direct vision is when we're looking directly inside the mouth without using a mouth mirror. So if we're just bending over, looking in the mouth, that would be direct. We're directly looking with our eyes. And then indirect is going to be using a mirror to look at the surfaces. So especially if we're working on a top tooth, we're typically using a mirror to be able to see back there instead of bending our bodies the whole way over to try to look in there. If we're not for the dental mouth mirror, the operator might have to bend. So that's what we want to avoid, because that's going to wreak havoc on our body over time if we're just constantly bending to look into the mouth where we need to see. So indirect, again, with a mirror. Direct is just directly with our eyes looking right at the tooth. Next, principles of instrumentation. So each instrument has three basic parts. There's the working end, which is what we're using in the mouth or whatever we're using. It provides the function. Then we have the shank, which is going to connect the two ends together, and then the handle, which is what we're going to hold. So there are four basic principles of instrument use. The first is grasp, second is finger rest or fulcrums, third is adaptation, and the fourth is activation. We'll talk about those more in the upcoming slides. So first is grasp. This is how you are holding your instrument. It provides control for the instrument while allowing flexibility of motions and precise adaptation. It also aids in the prevention of muscle fatigue. There are four different grasps that are used with hand instruments according to your textbooks for this class. The first is pen, which is shown in the picture here, and it offers the greatest control of instrumentation. So this is typically how you're going to be holding your instruments. There's also something called modified pen, which you can see in the textbook. Also palm thumb. So palm thumb would be mostly what we use, like if you're holding your sectional forceps or even like rubber dam forceps, where you're kind of holding it like this. And then there's also a modified palm thumb as well. Examples of all these can be found in your textbook. So there are compactors, which are used to condense or adapt amalgams, composites, temporary materials into cavity preps. They're usually double-ended. Amalgam compactors, which are also called condensers, have a diamond or a round shape to them. So as you can see in this picture here, that flat surface on the very end, that working end, is going to be good for pushing the materials down into the cavity prep, ensuring that no voids are present. There's also composite compactors, which are spatula-shaped and have a narrow nib-shaped working end. So more like this. They're great for adapting composites in there. And then on that reverse side, where there is a ball burnisher or an acorn burnisher, it's good for shaping the composite as well after you condense it. Then we have carvers. So carvers are used to remove excess amalgam, composite, or temporary filling materials from the preparation and helps to contour as well. So the working end has a sharp cutting edge that is formed by the junction of two surfaces at an acute angle. There are many different sizes and shapes of carvers. So an example in the pictures there, on the top is a cleoid discoid. Can also sometimes be reversed discoid cleoid. I've seen it either way. And then at the bottom there is an example of a Hollenbach carver. Then we have burnishers. So burnishers are used to rub and smooth amalgam after it has been placed in the cavity prep. Can be single or double-sided. Working end can have a round football or blade shape. No sharp edges or points, so it won't cut or scratch the amalgam. I also use these in composites as well. Again, we just saw the slide on composite condensers, and a lot of the composite condensers are universal, where they also have a burnisher on the opposite side of the condensing portion. So you can easily condense and then also burnish the area. So while it does a great job at smoothing the amalgam and making it shinier, I also use it for the composite as well, just to smooth things out and make it more flush and fluid of a filling. Next is using a fulcrum, or a finger rest. It helps to stabilize the hand to reduce chances of slipping or traumatizing tissues in the mouth. Super important, you don't want to do that. So ideally the third finger is used for the finger rest, and additional support is achieved when the second finger rests against the third and fourth finger and the entire hand moves as a unit. And then ideally your fulcrum should be positioned on the same arch that you're working on. So in the photo here on the slide, you can see that there is a finger rest on the opposite side of where they're working on, but the same arch. This is just going to make sure that your hand is stabilized, just in case you would get bumped or the patient moves or something, that you're not accidentally cutting into their tissues. Next, we have adaptation. Adaptation is the relationship between the working end of the instrument and the tooth surface. So instruments with cutting edges must be adapted to the restorative material so that only thin, small layers of material are removed at one time. So how do we do this? Essentially, we hold the working end of the instrument at a 90-degree angle to the surface that's being carved. We kind of want to hold the instrument almost like along the cusp of the teeth and let the cusps guide the instrument as we're adapting and kind of moving the filling material around, whether we're condensing it even or carving it, making marginal ridges, things like that. We always want to be conscious of how we're holding the instrument. And turning the cutting edge into the restorative material at too great of an angle could result in removing too much material at one time, which could create a defect that's not correctable. So the filling would have to be replaced, especially if it's amalgam. If it's getting hardened already and you start to try to carve into it and you take out too much, most times the amalgam needs to be replaced. So we don't want that to occur. So just taking small, thin layers at a time off is your best option. And then last we have activation. Activation is you actually moving the instrument. So we have two ways to move an instrument. The first way is just by moving your hand, wrist, and forearm all as one unit while keeping your finger rest, your fulcrum, in place. So you're essentially keeping your fingers there, just moving your arm side to side. The second way then is actually flexing your fingers back and forth. This can lead to cramping, muscle fatigue if you're doing it too much. Your fingers just can't take the grunt of all of it. So it's best to kind of keep your fingers still and move your forearm and wrist where you need it to go rather than your fingers. So let's talk about some restorative terminology. So let's get into some basic dental terms. First we have maxillary, which are teeth in the upper jaw, and mandibular, teeth in the lower jaw. Anterior refers to teeth towards the front of the mouth, so canines, lateral incisors, central incisors, and then posterior is going to be in the back of the mouth, so your premolars and molars. Mesial is going to refer to the closest area to the midline of the face. So midline right in the center here, whatever side's closest to the center of your nose is going to be mesial, whereas the part that's furthest away from the nose, from the midline, is distal. Occlusal are going to be the chewing surfaces, the top surfaces of the posterior teeth, and then incisal edges are going to be the biting edges of the front teeth. Facial is the side that faces the cheeks or lips on anterior teeth, whereas buccal is that same surface but for posterior teeth. These sometimes are used a little more interchangeably, but generally facial is for the front and buccal is for the back. And then labial can refer to surfaces towards the lips, whereas lingual refers to surfaces that are closer to the tongue area. Next, armamentarium. So anytime that we use the phrase armamentarium, it's going to refer to any of the equipment and instruments that are going to be used for that procedure. So you may hear this word a lot. It's kind of a mouthful to say, armamentarium, just your basic setup. Let's get into types of teeth though. So we have the incisors first. They're in the front of the mouth. They cut food for us. Next is the canines. So they are the longest teeth in our mouths. They are located at the corner of the mouth. Some people call them the cornerstone or even the keystone of the mouth. They are used to cut and tear food for us. Then we have premolars. So they have pointed buccal cusps that hold food while the lingual cusps help to grind the food. And there are no premolars in the primary dentition. So very important to know that children with their baby teeth still do not have premolars. And then we have molars last. So they are much larger than premolars. They have 4 or more cusps and they chew and grind our food for us. So let's talk about incisors a little bit more. They include the maxillary and mandibular central incisors and the lateral incisors. They're usually single rooted, so just one root there, and primarily used for cutting foods. Maxillary central incisors are the widest mesiodistally of any anterior tooth. So from like here to here, obviously the widest of the teeth. They can vary in form more than any other tooth in the mouth, except the third molar. Mandibular incisors are smaller mesiodistally than any other tooth, so the ones on top are the widest, the ones on the bottom are the smallest. So next we have the canines, which are also often called cuspids. They're used to cut and tear food. The maxillary canine is the longest tooth in our mouths. The maxillary canine is also the most stable tooth in the dental arch due to its root length and buccolingual thickness. So it's going to kind of stabilize our whole mouth based upon the maxillary canines. Often called the keystone of. Right. Next we have premolars, also known as bicuspids because they have two cusps. They're used to grasp, tear, and pulverize food for us. Second premolars generally have cusps that are not as sharp as first premolars, just in general with all of the premolars in our mouth. Let's talk about maxillary premolars next. So maxillary premolars have well-developed lingual cusps with a longer, sharp buccal cusp. So their buccal cusps are a little bit longer, whereas the lingual side is a little bit shorter. Maxillary first premolars usually have two roots, while maxillary second premolars usually have one root. And then for mandibular premolars, the mandibular first premolar is smaller than the second mandibular premolar, and both mandibular premolars usually just have one root. So next we have molars. So molars are used to grind foods for us. We'll talk about the maxillary first. The maxillary first molar in particular is different in design than any of the other teeth in our mouth, even the molars. It assists the mandibular molars in a major portion of the work of mastification, which is chewing. They are the largest and strongest teeth in the maxillary arch. So we've talked about the central incisors being the largest teeth mesiodistally, and the canines being the longest from like root to tip. But the maxillary first molars are just like the broadest and biggest overall, not just specific lengths. And they are the strongest. They have 3 full-size roots, 4 well-developed cusps, and sometimes a 5th cusp, which is known as the cusp of Caraveli. So a lot of people have this extra cusp, but not everyone, so we just say that there's at least 4 cusps, sometimes 5. That picture that just popped up, circled, is that extra cusp of Caraveli. And the maxillary second molars have a crown that is shorter than the first molar. It has 4 cusps and 3 roots as well. So then we'll go into mandibular molars. Mandibular molars are the largest and strongest teeth in the mandibular arch. The mandibular first molar is the largest tooth in the mandibular arch. It has 5 cusps and usually just 2 roots. The mandibular second molar has similar anatomy to the mandibular first molar, but is smaller and has 1 less cusp. So only 4 cusps. So then we're going to talk about crowns of teeth. So the crown is where the enamel covers dentin, and the dentin covers the pulp cavity of the tooth. The CEJ, the cemento-enamel junction, is the external line at the neck or cervix of the tooth where the enamel of the crown and the cementum of the root usually meet together. So in that picture on the side, you can see where there's kind of like 2 colors there. They have the crown color and then the root color. Where those colors meet is that CEJ line. So it's kind of cool that you can visually see it. There's types of crowns. There's anatomical crown, which is the part of the crown that it's where like the enamel is meeting the root, and sometimes you can not see the whole part of it because it's covered by gum tissues. So on the other hand, the clinical crown is the part of the crown that you can see out of the gums. So a little bit of difference there. We'll talk about that now again. So anatomical crown, portion that extends from the incisal or occlusal surface, so very tip of the tooth, to the CEJ line. So part of the anatomical crown may not be visible if it's under the gum tissues. And the CEJ dictates the contours of restorations placed in this area of the tooth. So we always want to use the CEJ kind of like, almost like a mold of where we want to place our fillings at, because we typically the tooth indents a little bit in that area, so we need to anatomically make sure it follows that CEJ line. And then the clinical crown is where we're actually seeing above the gum tissue. So if a person has recession, we may see their entire crown clinically, but if they have nice healthy gums that are kind of above that CEJ line, we may only see the clinical portion above, and there's a little bit remaining below yet, which we don't see. Then we have the roots of the teeth. So molars and some premolars generally have more than one root. And where those roots kind of come together, or where they divide at, is called the furcation. So you can see in the picture, all the way to the side, there is that furcation is right in the middle of those two roots, so where they split. And then a furrow is a concavity that extends to or nearly to the CEJ line. So in that picture as well, you can see they have the furrow highlighted there. It's kind of hard to see because it's more so not like a dark area or split. It's more so just like a carved out concavity seen on the tooth. And when placing a filling in or near the furrow, the operator must be aware of the anatomy to avoid over-contouring the restoration. So we would, again, it's a concavity. We don't want it to be like convex at all, like going outwards. But we also don't want to make it go too inwards, or it's going to harbor bacteria there. So there's kind of a fine line of exactly how concave that area of the furrow needs to be. Alright, so basic tooth numbering. I'm sure most of you know this already. We're just going to kind of cover this quickly. So permanent teeth are numbered 1 to 32, starting with the third molar, number 1, on the upper right side. And then we're going to go over to the top left, go down to the bottom left, and then end back up on the bottom right side. So that'll end your number 32 tooth there. An easy way to remember is to start by memorizing the canines. So 6, 11, 22, 27, kind of, again, the keystones of the arch there. So if you can remember those numbers, you can typically just count backwards or forwards to get to all the other teeth pretty easily. And even if a tooth is missing, you still need to count it as if it were there. So even if, we'll say, number 3 is missing, we can't then call number 4 number 3 to replace it. We have to just skip over number 3 and then continue with number 4, if that makes sense. Alright, so then for baby teeth, lettered A to T instead of 1 to 32. And same direction though, you're going to start on the top right side, go to the top left, go down to the bottom left, go over and end on the bottom right side. But it's just using letters instead of numbers. So you can see here in these pictures a little bit different. Permanent teeth are numbered, primary teeth are lettered. And then we have dental arch division. So we have quadrants when the maxillary and mandibular arches are divided in halves. So then each quadrant would have 8 teeth. So we have like the upper left quadrant, the upper right quadrant, the lower left quadrant, the lower right quadrant. So 4 quadrants total. And then you can also split into sextants, not as common, but can be done. So sextants is each arch is split into 3 areas. So it'll be the 2 posterior sides and then the 1 anterior side. And then same for the bottom, 2 posteriors, 1 anterior, all together equals 6, hence sextant. Okay, so histological structures. Histological structures of enamel first. So enamel covers the anatomical crown of the tooth. It varies in thickness in different areas of the tooth. It's usually thicker at the incisal edge and inclusal areas, and then thinner as it gets closer to the root. It is usually semi-translucent, and the color varies from yellow to grayish sometimes, whites, anything in between there. You've seen shade guides before. There's lots of different colors of what enamel can look like. It is the hardest tissue in the body, but it is very brittle. And it is composed of about 95% inorganic matter, mainly hydroxy of apatite, and 5% organic matter and water. So enamel is composed of rods or prisms that are formed as cells called ameloblasts. The rods tend to break off unless supported by sound dentin. And to ensure that rods are supported by sound dentin, the enamel wall of a preparation is at a 90-degree or more angle relative to the unprepared enamel. That way we make sure that the tooth is not prone to fracturing. Next, we'll go to dentin. So dentin makes up the bulk of the tooth just under the enamel. It is the second hardest material in the body, but is more elastic than enamel, so a little bit more flexible. It provides support for the enamel and protects and insulates the pulp as well from outside stimuli, and increases in hardness as you age. So the older that you get, the harder the dentin becomes. Typically yellowish white, and it's darker than enamel. So if you've ever seen like stump shades used for when doing like crown or veneer cases, the enamel colors are definitely darker and more yellow than what you would see on a typical enamel shade guide. Histological structure of dentin. So dentin is composed of about 70% inorganic matter, 20% organic matter, and 10% water. It is formed by cells called odontoblasts and consists of tunnels called dental tubules. So you can see in this picture here, those little holes, craters, are the dental tubules. This is kind of what opens up when we're etching a tooth. The etch kind of helps remove any of the debris in those tubules to open them up, and then the adhesive is able to kind of soak down into those tubules and you're able to get a better bond. So there's three major types of dentin. Number one is primary. It's produced before and shortly after the tooth erupts initially. And then secondary dentin forms at a slow rate as the tooth ages and throughout the life of the tooth. And then there's also reparative or tertiary dentin. This is a defense action from injury. It forms rapidly when the tooth receives any negative stimulus. So if there's a cavity, if the tooth gets prepped for a filling, or any trauma, the tooth gets hit or something, then this reparative dentin starts to form. Alright, histological structure of cementum. So cementum is the hard dental tissue covering the anatomical roots of the teeth. It is the fourth hardest material in the body. So enamel, dentin, and bone are all harder than cementum, but still, that's pretty high up on the list. It's formed by cells called cementoblasts, usually light yellow to slightly darker than dentin in color. So you can definitely see a difference compared to enamel. Maybe not so much closer to dentin, but if you compare cementum to enamel, big differences there in color. It has no blood supply of its own, but derives nutrition from the periodontal ligament to which it is attached to. So it doesn't have the pulp going through it, but it definitely gets some nutrients from the surrounding outside ligaments. So there's two types of cementum. There's acellular, which extends from the CEJ towards the root apex and covers a large portion of the root. It gets very thin near the CEJ and then thicker towards the root apex, and it cannot replace itself. So that's very important to know. Whereas cellular, it's located on the apex of the root, made up of cells that are actively producing new layers of cementum throughout the life of the tooth, so it can replace itself. And then we have the dental pulp. So the pulp provides the developmental, protective, and sensory mechanisms of the tooth. It's where all the nerve supply is located. Provides nutrients and the metabolic processes. Pulp is inside the pulp chamber with one or more root canals. So if there is a two root, as you can see in this picture, this tooth has two roots, and then above where those two roots are meeting at is that pulp chamber, where it's just a wider, broader area for the pulp to be located in. And the size of the pulp and pulp chamber reduces with age. So the older we get, the smaller it gets. So continuing with the dental pulp, the pulp is divided into two parts. So the coronal pulp is located in the pulp chamber in the crown portion of the tooth. It includes the pulp horns, whereas the radicular pulp is located in the pulp canals in the roots of the teeth. So if you can see on the picture on the side, the coronal pulp towards the top splits into almost two horn areas, and then the radicular pulp is going down the roots of the teeth. So the pulp serves four basic functions. Number one is formative developmental. It produces primary and secondary dentin. Number two, nutritive, supplies nutrients and fluids to the dentin through the blood supply. Number three, sensory, provides sensory nerve fibers within the pulp to mediate the sensation of pain. And then number four, defensive protective. So severe trauma can cause degeneration or death of pulpal cells. So next, dental anatomy. The cusp of the teeth the cusp is a major developmental convexity on or near the occlusal surface of a posterior tooth. Can be also found on the incisal edges of canines. A premolar usually has 2 cusps, a buccal and a lingual, and molars usually have 3 to 5 cusps. The cusp of Carabelli is that extra 5th lingual cusp on maxillary first molars we talked about a few slides ago. Then we have ridges. So a ridge is any narrow linear developmental elevation on the surface of a tooth. It is different than a cusp. Ridges are identified as being mesial, distal, lingual, or buccal according to the location, and ridges are also further classified according to their location on the tooth surface and direction in which they transverse the surface. So if you can see in the picture here, there's quite a few different types of ridges, like names will say. There is a marginal ridge, an oblique ridge, distolingual cusp ridge, a buccocervical ridge, mesiobuccal cusp ridge, transverse ridge, marginal ridge, again, and then a mesiolingual cusp ridge. So lots of different types of ridge names, but again, they are different than cusp. If you can see, like in this picture, there are distinct cusps that are with the very dark black lines. And then those dotted lines are those ridges. So a marginal ridge then is an elevation of enamel which forms the mesial or distal margin of the lingual surface of an anterior tooth or the occlusal surface of a posterior tooth. So as you can see in these pictures here, for a posterior tooth, it's that pinkish purplish color. Mesodistally on the tooth, and then for an anterior tooth, it's this green color again, mesodistally, but it's on the lingual side of the tooth. Triangular ridge. A triangular ridge is a ridge on a molar or premolar that descends from the tips of the cusps towards the central part of the occlusal surface. They are named triangular ridges because the slopes of the sides of the ridges are inclined like the two sides of a triangle, narrow at its tip and then broader at its base. So in the picture here, you can see that purpley pink color again is the triangular ridge. It makes a triangular shape. Transverse ridges then are ridges formed by the union of 2 triangular ridges that extend across the surface of a posterior tooth. So cusp ridges either run perpendicular to the central dissectional groove, transverse, or at an angle, oblique. They are named according to the position they occupy, mesially or distally. So as you can see on the pictures here, the transverse cusp ridge kind of right in the center there. The oblique cusp ridges are more towards the outside of the molars, and then there's also the oblique cusp ridge of a premolar, which is almost making again a triangular pattern, but that top portion is more right in the center of that buccal cusp. Oblique ridges then are a ridge crossing the occlusal surface of only maxillary molars in an oblique direction. It is formed by 2 triangular ridges extending from the distal buccal to the mesiolingual cusp. There is only 1 oblique ridge on each maxillary molar. The cingulum then is the lingual lobe of an anterior tooth located in the gingival area of the lingual surface. And next we have fossa. So fossae are irregular, rounded, or angular depressions or concavities on the occlusal surface of a posterior tooth bordered by the cusp ridges and the occlusal table. They can also be on anterior teeth as well, which we'll find out here in a second. But as you can see in the picture there, those green areas are all have like a pit in the center of the green area. So the fossa is that area that's starting to go downward into the center of that pit. There's 4 major fossae to remember. The first one is the lingual fossa on anterior teeth. There's the central fossa on molars. So you can see in this green picture, the one right in the center there, the central fossa on 3 cusp premolars. And then there's also mesial and distal triangular fossa on the premolars and molars. So in this picture here, it would be the more outside green areas. So that middle one would be the central fossa, and then the mesial distally sided ones are the triangular fossa. Alright, so this slide is just going to show some better examples of each type of fossa. So the lingual fossa there, as you can see on the back side of anterior teeth, you can kind of feel it with your tongue if you would go to feel your anterior teeth. It's just kind of like almost like a little concave area that's dipping down, whereas the cingulum is more towards the bottom there, that is more convex and goes outwards. And then we have the central fossa. Like we mentioned in the last slide, it's that very center portion of that middle pit. And then the triangular fossa is more so on the mesial and distal side of the posterior teeth. Next, we have developmental grooves. So developmental grooves are major grooves or lines between the ridges of the teeth. Posterior teeth, they separate the cusp of the teeth. So as you can see in this picture, that is a posterior tooth, and those developmental grooves are in between all of the cusps. They're named according to their location on the tooth surface, and some common developmental grooves include the central developmental groove, which is running mesial to distally in this picture that is shown. We have the buccal developmental groove, we have the lingual developmental groove, and the supplemental groove as well. So in this picture here, that central developmental groove, it is going mesial distal direction, and then the buccal development groove is separating the two buccal cusps of the molars. So some people get decay in that buccal groove as well, that it would be like a class 5 filling there. There's lingual developmental grooves, so same as the buccal side, but on the lingual side towards the tongue. It just separates those two lingual cusps. And then there's supplemental grooves as well, which are just smaller little grooves that kind of go up into the cusp a little bit. Next we have pits. So those are those little circles that are down at the most shallow point of the fossa. So they're small pinpoint depressions located at the junction of developmental grooves or at the termination of these grooves. They result from incomplete closure of 3 or more adjacent lobes or developmental grooves. So the pits are forming because the teeth didn't properly close together when forming. Tip of an explorer may extend into or stick in a pit. And then we have fissures. So fissures are developmental or supplemental grooves with incomplete closure of enamel. So fissures are a lot of the times the reasons that we are placing sealants on patients, because those grooves did not close all the way, the enamel didn't fully form together, and now you're left with areas where a lot of bacteria can get stuck in there and harbor. An explorer may catch or stick in a fissure because of the incomplete closure of enamel. Sealants are placed in these fissures and pits.